My name is Dr. Mitsamajero, and I'm the lead clinical consultant for the Refugee and Migrant Technical Assistance Center for Behavioral Health, also known as RMTAC. I'm excited to welcome you all to the third session of Learning Community Cohort 2. Today, we'll be diving into the topic of integrating a multidisciplinary team as we work with refugees and migrants, but we're specifically going to be focusing on treatment planning and communication and peer support in today's session. With me today, serving as our co-host, is Dr. Brandon Osborne, who's a Senior Research Associate at AMTC and Associates. I'll give Dr. Brandon a second to introduce himself.
Thanks, Dr. Mutsa. And thank you everyone for joining us today. It's an absolute privilege to have each of you joining as part of this learning community. If this is your first time joining us today, we encourage everyone to actively participate. Feel free to ask questions, share your insights, and support one another through this session. We hope this learning community is able to foster a collaborative environment where we can share knowledge, resources, and best practices. And through our collective experiences and expertise, we, as Dr. Mutsa said, aim to enhance obviously the interdisciplinary nature of this work, but also just the broader capacity of our organizations, the work we do to improve service delivery and make a more significant impact of those we serve. So again, thank you.
Wonderful. Thank you, Dr. Brandon. All right, on the next slide, you'll see our agenda for the day. We've got a lot of great things planned for today's session. We will briefly recap what we covered in the first two sessions of this learning community, as well as identify the goals and outcomes for today's session. We'll also hear from our subject matter expert on the topic of implementing a multidisciplinary approach to treatment planning and peer support. And we will have an opportunity to engage in some discussions and activities. I'm excited to introduce our subject matter expert, who we will be hearing from shortly. Chris Villalobos is a team leader and program director of Brooklyn Intensive Mobile Center at CASES, or Center for Alternative Sentencing and Employment Services. Thank you, Chris, for your time and commitment. Looking forward to hearing more from you shortly. I would also like to introduce our subject matter experts and facilitators, who you will hear from when we split up into breakout rooms later in the session. They are also clinical consultants on the RMTAC team. So thank you to Luz Chapa, Dr. Mohammed Ziali, and Esther Rodriguez. Also from the RMTAC team, we have our team of producers today. They will be helping to make sure that everything runs smoothly. If you encounter any technical difficulties throughout this session, please feel free to reach out to either Diana, Rosa, Sonia, Titus, or Alex. You can see their names appear on their video screen. So thank you to the RMTAC team for your support throughout today's session. So at this point, we're just going to recap what we have discussed in session 1 and 2, and then just kind of dive in a little bit into what session 3 today is going to look like. So in our first session, we were able to identify the elements that comprise a multidisciplinary team, including the different roles and responsibilities and the benefits of collaboration and mutual support amongst us as providers. In our second session, we examined the importance of utilizing such a team to tackle the barriers and challenges that refugees and migrants typically face when they're accessing care. We discussed some strategies to address these barriers in an effort to improve health outcomes for this population. And now in today's session, we will explore the topic of utilizing a multidisciplinary approach to implement person-centered treatment planning and the importance of our communication and peer support in this entire process. So a lot of what you all noted in the chat just now with the icebreaker activity is going to come to play throughout today's session. As mentioned by Dr. Brandon, this learning community is intended to be very engaging and collaborative. So we highly encourage you all to take advantage of the knowledgeable individuals that we have in this session by being a very active participant. And so by the end of this session, on the next slide, by the end of the session, you'll be able to finalize a care plan for refugee and migrant clients utilizing a collaborative care model approach. So a big part of this learning community involves the opportunity to analyze a case study of a migrant client in order for you to develop effective and we hope that you'll be able to develop effective strategies that you can use in your work as you collaborate with the refugees and migrants that you serve. Today, you'll get an update on the client's status. So from session 1 and session 2, we discussed a migrant client. Today, you'll get a status on where this client currently is, and you'll be able to participate in a discussion to develop their care plan. So we hope that you'll be able to apply some of these strategies, again, with some of the complex cases that you all may encounter with the refugees and migrants that you serve. And it's going to be important for us to highlight throughout today's session, just as we have in all sessions, the importance of collaborating with peers, right? So collaborating with peers to better serve refugees and migrants is really crucial in the work that we do. A multidisciplinary team strives to enhance healthcare delivery for these populations, and a significant aspect of that involves the type of communication we have amongst ourselves as providers. This teamwork offers, or at least it allows us to offer, a holistic support and address various health and social needs, improving access to resources and ensuring that there's a solid continuity of care. Collaboration is also really important because it facilitates the sharing of cultural knowledge, which can serve to enhance cultural competence and humility. And additionally, it strengthens our advocacy efforts, and that can help protect the refugees and migrants that we serve. So by working together, we can also share the workload, reduce burnout, and provide the best possible care that we can for our clients.
Thank you, Mutsa. So at this point, we would like to introduce our case study to prepare us for our breakout rooms, where we will be applying our expertise to developing a care plan. So in our previous sessions, we met Sanda, a 19-year-old female from Myanmar, formerly known as Burma, while she was seeking medical treatment for a UTI at a federally qualified health center. During this appointment, it was discovered, unbeknownst to Sanda, that she was 6 weeks pregnant. And upon further investigation, it was determined that Sanda was experiencing labor trafficking along with 11 other young women from Myanmar and other parts of East Asia, like Vietnam and Cambodia. And they were all living together in a 3-bedroom trailer. Sanda and a few of the other women with whom she was living were moved into a domestic violence shelter due to a lack of trafficking-specific shelters. And after a 3-month waiting period, Sanda was able to meet with a pro bono lawyer to discuss her options for obtaining legal status. She struggled to understand the content and the American legal system, despite having an interpreter present. And during the meeting, Sanda shared that she was forced to marry a man 20 years her senior when she was just 14 years old. She was forced to undergo virginity and fertility testing, and she was threatened with honor violence if she did not comply. She also disclosed that her husband had been physically and sexually abusive toward her, and he did not allow her to work or finish her education. When we move out into the breakout sessions, we'll be working with Sanda again to learn where she is now so that we can develop a care plan that aligns with her goals for life in the US.
In our previous sessions, the clinical consultant team shared a case study that was developed for our participants to review. And throughout each session, we shared parts of Sanda's case, and together we were able to develop effective strategies, identify barriers and challenges. And today, in our last session, the purpose of today's case study is to analyze Sanda's current situation and to develop her care plan while using a multidisciplinary approach through collaboration. We ask that you please picture this case in your work settings, and though some details may not completely match your duties or role, we ask that you imagine that they do as you work collaboratively together through the care plan of Sanda. So in this activity, we will do a breakout into small groups. Each of the groups will have a subject matter expert and facilitator and a producer. Your group discussion will be guided by your assigned facilitator, and the producer assigned to the group will be taking notes on screen. We ask each group to select the one person to share the group summary when we return back to the main group discussion. We look forward to the meaningful conversations and productive collaborations that lie ahead. Thank you.
Hopefully working through this case with some of our clinical case consultants just goes to show the level of expertise and support that RMTAC, our center, can support you all when working with your clients and patients, especially complex cases like these that, may require, just some validation or maybe someone's second opinion on. But now we'd like to introduce our subject matter expert for today, who will be facilitating the main discussion. So we're joined by Chris Villalobos. Chris is a licensed mental health counselor in New York City and the proud son of a Guatemalan immigrant mother. He currently leads an intensive mobile treatment team at the Center for Alternative Sentencing and Employment Services, also known as CASES. There, his interdisciplinary program is designed to serve New Yorkers with the highest level of mental health need. And he handles all aspects of care, including medical, psychiatric, housing, legal, substance use, and more. Chris has always been passionate about crisis work and immigrant and refugee populations. He spent the last 15 years working with community mental health, providing crisis intervention and mobile services to adults and children diagnosed with mental and behavioral disorders. Beyond his work in DC, Oklahoma, New York City, he has spent time volunteering with diverse immigrant and refugee populations, including at the US-Mexico border, in Clarkson, Georgia, and internationally. He's a first-generation college graduate and holds a bachelor's degree in psychology and a master's degree in counseling from Oral Roberts University. Thank you for joining us today, Chris. Really looking forward to your talk, and go ahead and take it away.
Yeah, thank you. I appreciate that. Again, my name is Chris Villalobos. I'm a licensed mental health counselor here in the state of New York, in New York City. As he mentioned, I currently working with an intensive mobile treatment team. It's a team that serves we have 27 clients in our program with about there's 9 staff, 9 of us on our treatment team. Those clients get referred to us through the city of New York, and it's based upon basically people who are adults who are high level of need, who are in and out of the different systems, oftentimes are either not wanting to be in any sort of mental health treatment, or they're just not stable enough or not in stable environments where they can kind of succeed in an typical like outpatient setting. So that is how we have been organized. So what we'll discuss is kind of the main group. We'll do the main group discussion regarding Sanda's case that we just discussed as far as treatment planning. So hopefully, I'm not sure how many groups there were, but we'll discuss kind of what we kind of came up with in our groups. So how would Sanda's care plan apply to a specific client that you have served or are currently serving in your organizations?
2 groups.
2 groups. Great. Thank you. All right. Well, I am going for group 1. So, yeah, in group 1, right? So we discussed a few of the different areas that we would kind of look into. Some of that was, of course, like some of her stated goals of wanting to get her education. So looking into GED classes as well as ESL classes, since we assume, English is not her primary language at this point. So making sure that she has those resources to figuring out whether or not those are offered within her current setting at the women's shelter or the pregnancy shelter, or if that would be something we need to look into in the community, as well as figuring out her immigration lawyer situation. I know she met with one while at the DV shelter. However, she's in a new setting now. So if those services can't be transferred over, looking for a new lawyer that can assist with that status. Looking into like workforce development, that was one of her stated goals. So a technical school, figuring out what resources are available in the community that might be able to assist her. We talked about, some people spoke about some of the resources within their respective communities, including, I know there was one place that offered, childcare services and all these different things so that people could receive the training and the services that they need without having any barriers. So something like that would be important for her, especially as once she has the child. Looked at different support systems, cultural systems, those sort of things that she's going to need. And then we talked about just kind of like the issues regarding her, any mental health care that she may receive or may want to receive or not want to receive just because of cultural barriers and things, and just, you know, taking into account her desire to pursue those, you know, at this time, given maybe, you know, some of the cultural issues that may come up with her, maybe not feeling comfortable with, you know, talking about the trauma that she's experienced, or comfortable with like psychiatric medications and things like that. So just letting her kind of be the expert and take the lead on what she is, you know, willing to do at that time, and supporting her in however we can in that time. So I think that was most everything we talked about. Did group 2 have anything to add?
Just kind of echoing some of what you already mentioned. Our group mainly focused on her mental health and medical needs. Like you talked about. Well, one, we talked again about the importance of keeping her involved in her treatment in all conversations. Also understanding from her, from a cultural perspective, how she felt about, medication. Whether it's taking it while she's pregnant or after pregnant. We talked about, you know, if she was the possibility of her wanting to breastfeed, how taking medication can interact with that. Also, making sure that she receives follow services from a psychiatrist since anxiety and possible depression and possible postpartum depression was a concern. Trying to think. And then, we talked about, her having the prenatal, postnatal care, talking to a nutrition, receiving regular checkups and prenatal vitamins. We kind of the bulk of our conversation was on that. Mohammed, he shared a little bit about possible medication that clients in this situation, may take, such as possibly Paxil. But again, just making sure that it's something that the client would be comfortable with taking. And that was it.
All right. Yeah, no, that's great. Yeah, that was a lot of the focus that we had, right? Is having the complications of cultural factors, but then also like just, legitimate medical concerns while she's pregnant, what she's able to do. And so yeah, there are a lot of different things that need to be accounted for. One of those we talked about was, interpreters, and kind of figuring out what those circumstances were going to look like. Are we going to have an interpreter in person? Is this going to be a remote, phone or video interpreting service? Are we going to be able to find an interpreter in the appropriate dialect of the language that she may speak? So a lot of things to kind of consider when not just creating the treatment plan, but then also just actually implementing it and helping her get these services. So today we're going to kind of bring all of this together and go further into kind of creating a deeper impact there. So we've discussed how to build a multidisciplinary team in the previous sessions. So I'll be kind of just briefly reviewing some of that perspective, and just kind of highlighting some of my own personal experience with multidisciplinary teams. So if you're building a team, some of you are probably in different situations. So if you're building a team from scratch, and, you may have the time to really kind of think through like the different sort of services that you're going to be offering. Or if you're already in a ecosystem that exists, and you're just trying to figure out how to provide services within the multidisciplinary team that you have, or maybe figuring out what room you may have to grow or expand that. We'll kind of be discussing some of those things and how to go about thinking about that. So kind of the big thing I like to think about is just, figuring out, doing your research, figuring out who it is that you're serving, what types of migrants you're dealing with. Are these refugees, asylees? Are these immigrants who are here, legally? Are these immigrants who are here illegally? Those are going to kind of inform some of the types of services that you offer or provide, or how you even go about providing services to some of these people. What countries and cultures are the migrants coming from? Depending on where you work, you may have a very large variety of different cultures that you're serving. Other places may have very specific, cultures that are there, and depending on, what types of people are coming, and if these are people who are being brought over via, refugees that are being brought over via the UN, you may have, one specific country, or maybe a few different countries that are kind of the dominant population that you're serving there. So knowing where those backgrounds are going to help you kind of inform what you need to do to move forward. And so if you're at the beginning stages of that, conducting a needs assessment, figuring out like what it is that you need to provide. So some of that might be, you might need to speak with government officials and agencies about the number of refugees and migrants in your area. You might you'll definitely want to speak with like refugees and migrants about the particular needs that they have, trying to live in your community, speaking with those people, figuring out what it is that they are needing, what it is that is missing, what are they finding difficult to obtain. And so when we say needs assessment, we're talking on the more macro level of like trying to figure out what are the needs, and now how do we build something to bring that together. Creating that multidisciplinary team. We've got a list here of some of the sort of professions and job titles, that sort of disciplines that you may be dealing with and may comprise some of your team. As I mentioned earlier, in the current program that I serve, we're serving 27 clients with various different needs. There's 9 staff. Within my own team, like we've got 3 behavioral health specialists that are basically 3 different levels of education there in regards to mental health services. So we've got a licensed level social worker or counselor, depending on what their licensed discipline is. We'll have just like a master's level, someone who has a mental health adjacent education that may not necessarily have like the licensed clinical profession there. And then as well as like a bachelor level who kind of functions as more of like a case manager, might be again in an adjacent discipline, that sort of thing. We've got a psychiatric nurse practitioner who's providing the medication. We've got a registered nurse who is providing the injection medications, that is doing nursing assessments to kind of figure out what the health needs are there, making sure that people are getting connected to medical providers. So we don't have, direct medical care within our program. So we work with other agencies outside of us. And there's a few that we use regularly just because we know that it's easy for our clients to work with them. We have a longer working relationship with them. We have one that's really integrated in there. So those sort of things. But yeah, so something you might want to know. So if does your organization have the financial limitations to build in a robust treatment team? Then that's where you're going to want to outsource to some of these other needs. You're not providing medical services, so like finding primary care physicians, the other types of medical needs that you guys need for your team to make sure that people have, what they need. And so doing that requires you to build relationships with community partners to streamline all of that, and meeting with community partners regularly to address any issues that might be coming up. If you're having issues in referring people and getting people connected appropriately, making sure that you're able to meet with them on a regular basis to make things as smooth as possible for the people that you're serving. So moving on to a person-centered treatment plan, and how do we align that with a multidisciplinary team? Most of us, if you're in the mental health field and any sort of therapy environment, you understand what person-centered care involves, right? It's a collaborative approach to treatment planning. You're emphasizing the self-determination and the choice of the person that's in treatment, ensuring that their preferences, their needs, their values are guiding the clinical decisions. Basically, they're the expert, right? They're the expert on their life. You're going to follow their lead when it comes to helping them achieve the goals that they've set out. So the treatment planning, the work that you're doing is going to focus on what they have lined out as their goals, and you're going to help them figure out the best way to achieve them. You may think that they would highly benefit from, I don't know, trauma therapy, as we discussed with Sanda, but maybe that person isn't ready to move forward with that. So in that case, you may step back a little bit and focus on the things that they are ready to work on and move on from there. Now, as we kind of touched on a little bit, right? Like focusing on their specific goals, what they want to work on, is going to help refugees and migrants, people who are not familiar with our culture, really build confidence and create this positive environment for growth for them. They're going to feel confident in their ability to self-determine their life and guide their care and their treatment, and hopefully motivate them as well to continue on in the process and make positive change. Focusing on that can help practitioners learn about the refugees' culture and issues to better understand how to work with them. Hopefully you're building an environment of trust within that as you are focusing on what they want to do. They're feeling trusting of you and being able to share more, being able to kind of create an environment that is going to help you learn how to work better with them in a way that's culturally appropriate. And then in general, just foster holistic change for that individual as they focus on their issues. Next slide. So where do we need to begin treatment planning? Within my own program, where we kind of focus on things, and it's a little bit different than some other programs, we do a needs assessment. You can certainly focus on other forms of assessment, but by needs assessment, it's pretty simple. We're looking at the different areas of that person's life that we know they may have areas of need. Basic needs obviously are like those immediate things that they're going to need help with right away, right? They need food, they need clothing, assistance with hygiene. Maybe they need help, with transportation, figuring out how to get around, having, Metro cards or whatever, your environment might be. Housing is a big thing, right? If someone is living on the streets, it's going to be hard to, tackle some of those other areas of needs if their main issue is like they want someplace to live. So getting them into maybe a shelter temporarily until you can find more long-term housing, figuring out those processes. Medical, of course, if they have any ongoing medical needs that need to be addressed. We talked about psychiatric, right? So any therapy or medication management type needs, figuring out what those situations might require. Legal immigration needs, those sort of things are complicated and take time, but you want to make sure you get started on those. Any benefits that they may be eligible for, health insurance, public assistance, that kind of stuff. And then of course, and probably maybe one of the more important ones, is just kind of community integration and social supports. That might be, connecting them to other people, other migrants from their culture or similar cultures that they can kind of connect with and feel like they have the social support that they need in this new environment. Biopsychosocial assessments are probably well known for most people. I think just something you need to consider is whether or not that might be appropriate for the person you're dealing with. I think in a lot of settings, it's usually like one of the first things you do during an intake, and it's like an hour and a half or longer. That might be too much for that person. And so maybe trying to find something shorter that doesn't take as much time would be something that would benefit you if your agency can allow the space to do that. So moving on, some things to consider with treatment planning is just using an assessment tool that's been researched, validated to work with refugee populations. We've got here the Kessler Psychological Distress Scale, which is just 10 brief items that you can put in there. It's available in 72 different languages, something that you could definitely easily implement, and it just kind of provides a way of indicating to you whether or not there might be some areas of psychological distress that you might want to look into or address while treatment planning. And yeah, and when you have all that, triage those things and try to figure out a plan of action with the client on where to start and what to maybe save for a little bit later. Some considerations for providing person-centered care to refugees and migrants. So we talked about some of this already, right? We want to acknowledge these cultural differences. We want to be culturally appropriate with these things, develop, knowledge about the culture, consider their language and literacy. Are they even able to read in their own language? They may not have the education to do that. So those are things you're going to have to know and figure out, and then some of this stuff. So we're going to move on to the next page there. Excuse me. So communication and peer support. So this is what we talked about. So how do we engage and build trust with refugees and migrants and build that within the multidisciplinary team? Big thing to start, education for staff. You've talked about trauma-informed care, cultural competency. These are kind of like basic level things that you want to start with. I would say all levels of staff that are going to have any sort of, face contact with the client. In staffing, looking to hire multicultural staff. Peers. In this case, we're talking about like hiring, immigrant refugee staff, people who are from the same cultures, maybe speak the same languages that can work with those individuals. Because from my experience, the peers that I work with, again, in a different type of setting, just because the peers I work with are coming with backgrounds of just being familiar with their own mental health recovery or substance use recovery or, their criminal justice backgrounds, like these sort of things. But they're coming with that lived experience, and they're huge. They have a huge impact in working with clients that we work with who are just kind of maybe resistant and not trusting of institutions and just people that are not from the same background that they are. So having those peers are huge and like helping to build trust and kind of tear down some of those barriers that they might have with working with physicians and doctors and social workers and things like that. But a good thing to do as far as like first impressions when they walk in the door is creating a safe and welcoming space. I talk about warm handoffs, just making sure that you consider the program's ability to be being able to personally escort people from like area to area if you have the resources to do it, maybe being able to go out into the community to help them receive specific services. It can be helpful. Or, building relationships with other people outside of your agency so that you can call them, send an email, whatever, let them know like, hey, you're referring this person. These are the things that you might need to know about them. And then just removing communication barriers. Again, like I said, peers are excellent for that. I think that utilizing them in any way that you can is huge. I'm a big fan of utilizing peers in work with any type of client, whether that be a refugee or someone else. And utilizing that to break down barriers within the team. So, if you've got someone who's resistant to meeting with a psychiatrist or something that's on your treatment team, maybe they'll feel more comfortable, going with that peer to like sit through that initial appointment. So communication amongst the multidisciplinary team. I think this is a big important area. You want to develop clear lines of communication. You want to have clear processes and procedures lined out. I think, we've all worked in situations and teams within the agency where you're trying to get something done and something gets dropped along the way. Someone thought somebody else was working on something. Something was completed, but they never let you know like what the process was. These are all things that you want to try and address to not only make it, of course, to make things run smoothly for you, but also just for that person, for that client that you're working with. Excuse me. Because it's not fun for them to be in a fairly new culture, not necessarily know what's going on, and then kind of feel like they're left in limbo because one step of the process was completed, but it wasn't communicated to someone else down the line. So if you can, hold treatment team meetings with relevant staff. My team, again, we're very much like we're a very close-knit treatment team. So like we're having daily meetings, weekly meetings where we're going in depth about these things. That may or may not work for some of the settings that you guys are in, but like being able to have the ability to have a treatment team meeting to discuss maybe some of the higher need, more complicated cases that you have and how to kind of bridge those gaps that you're seeing. And then if there's any communication breakdowns, dealing with that stuff immediately so that you can facilitate a smooth treatment process. And that goes for working with community partners. I've worked with a number of different types of community partners in various roles and like have had to meet with them about issues that we were seeing and that were causing problems for us while we were delivering care and trying to figure out like how to smooth over those processes. And they get smoothed over for a little while and then things kind of fall apart again. And then you have to just kind of readdress those things as they come up to make sure things are working smoothly. So, and that last point there is just making sure everybody understands each other's role on the treatment team. I think is a big process. If everybody knows what they're supposed to be doing and who does what, it really helps things run smoothly, especially, and also helps just mitigate any sort of frustration you might feel with thinking somebody should be handling a particular area and that person is feeling that is someone else's role. So that is the end there. Yeah. So, but in general, I love to highlight on the peer stuff just because I've had such great successes working with peers in a number of different settings. And so, especially with the work that I do now, we deal with a lot of treatment-resistant clients that are not always open right away to working with you and dealing with certain things and working with individuals who are dealing with have dealt with some of the same issues that person has, really come from just same cultural backgrounds, like really help to break down some of those barriers, and it just leaves them more open to like receiving care. And so I think that is a huge thing that you can, if you don't have peers already within your system and you can build room to hire staff and create a position like that, I think that is a big help. That's it.
Wonderful. Thank you so much, Chris, for sharing your expertise and providing some really solid and practical examples of what this whole process can look like. So to briefly recap, I think Chris touched on a lot of key things related to what a multidisciplinary approach looks like and the importance of collaboration between providers. And the breakout room discussions also really highlighted the need for cultural humility throughout this whole process. And we will provide more in-depth breakdown of all 3 sessions that we've had for this learning community and some key takeaways in our handout that we will send to you all post this session. So please be on the lookout for that. And on this next slide, it highlights that it's so easy to get a hold of us for additional support. So if you need any assistance with implementing multidisciplinary approach, implementing a person-centered treatment planning, please feel free to reach out to our team and we can assist with this. You can submit a consultation request, really simple and easy on our website, and we'll respond to you within 1 to 3 business days.
Before we leave, everyone, we do ask that you please complete a brief survey that will be shared shortly, a QR code and a link. In addition, we'll be sending out a summary handout of today's session, just going over all the key points that was discussed. We'll also send out, as mentioned, the care plan template that we started to use during the breakout. We hope that you find that helpful with your future clients and patients. And also, we just want to plug our next learning community, which is going to be a two-part session, series on behavioral health and psychopharmacology for refugees and migrants. Our first session is scheduled for February 12th. So if you have any interest in that, please let us know and we'll get you all signed up for that. So next slide, please. And again, we're going to ask you to please take our survey. It's really quick, it's very short. It helps us improve these sessions while also meeting our grant funder SAMHSA's requirements. So thank you.
Wonderful. Thank you all so much. The survey is also in the chat, so please feel free to either scan or just complete it through the link. Once again, thank you all so much for your attention and your attentiveness throughout this learning community. Thank you, Chris, for your insight and expertise on this topic. All of our participants, we appreciate you taking time out of your busy days. Thank you to the RMTAC team for making all of this a success. And we hope you all enjoy the rest of your afternoon, and we look forward to seeing you next month for the next learning community.